Good morning, everybody, and welcome to the final session of the second year of the SCAI Bifurcation Club webinar series, which I had the privilege to host. It's an idea brought to SCAI, and I'm thankful to the leadership and also to Yanis Chatsisis and Josh Dangas to give me this opportunity to start it 2 years ago. It's been the most successful webinar series for SCAI, and I'm especially thankful to my international guests from the East Asia, the Middle East, Europe, would come up in odd hours of the night with wanting to participate in this really good program, which had thousands of viewers over the past 2 years. I want to thank the SCAI staff, particularly Laura Porter for her dedication, Kristen Perry, Amanda, Eric Grammer, and Bob Bartel to help me through this process. I want to also thank Medtronics for their sponsorship of this program for the past 2 years, and particularly Jason Fontana, Tom Tapper, Sarah Rowe, and Renee Drakakis, who was no longer Medtronic, but helped us get going. And I want to particularly thank all my colleagues who have been really, really wonderful in this. So anyway, this will be hosted by Bill Nicholson and Azim Lateef. I'm privileged to have my mentor and teacher, Dr. King, who was the president of SCAI in 1980, Bernardo Cortisi from Cleveland, Bernardo Alfonso Spain, and of course, Bruno Scheller from Germany, who's really worked in this area so many years and really taught us a great deal about drug-coated balloons. Without much ado, I'll pass it on to Bill and Azim to host the program. Thank you.
Yeah, thanks, Tanvir, and congratulations on the highly successful endeavor that you've spearheaded. So it's been great. So we've got a lot to get through. So we have 3 case presentations, and then Dr. King's got some interesting reminiscing about the past days of PTCA, which are obviously coming back. So we'll move ahead and let Dr. Cortisi start out with use of drug-coated balloons in recent and upcoming trials. Thanks, Bernardo.
Yeah, thank you. Thank you, William, for the presentation. I think that you need to allow me to share my screen. Yes, now can do that. Okay. So please confirm that you see my slides.
We can.
Okay, thank you. So, well, I'm very grateful to SCAI for this series of webinars on DCB. And I have to say also that DCB in the side branch and in the main vessel potentially for a complex bifurcation lesion is a very nice and appealing subset. So historically, we have a few meta-analyses showing that there's small studies done since the very beginning of the DCB era, back in 2007, are showing that the usage of DCB for specifically paclitaxel DCB for the side branch is associated to improved left lumen loss, sure, but also TLR as compared to POBA. Okay, so this is something that is quite clear. Then very recently, about a year ago, the DCB BIF trial has been published. In this study, with honestly, I would say, quite simple bifurcation lesions with a side branch lesion length maximum of 10 millimeters, with a strategy of main vessel stenting and then POT. Here, patients have been randomized to side branch treatment with DCB or non-compliant balloon. With such, I would say, a quite complex and meticulous technical approach for this study, with a kissing balloon, then repot, then stenting, and then again a kissing balloon, and then treatment of the side branch. But the thing here in this study is that in many cases, kissing balloon has been applied after drug delivery in the side branch. I would say almost always. And this is something that we suggest not to do. Intravascular imaging in this study was not used that much, only about one fourth of the patients. But anyhow, DCB here was shown to be superior to POBA with non-compliant balloon for the side branch, with a significant reduction of the target lesion failure, which is the primary endpoint of the study, which was halved by DCB treatment. And this composite endpoint actually was driven mostly by target vessel MI and spontaneous MI, which is something that is quite weird to see that there is a reduction in spontaneous MI. And it's still a question mark about this study. But anyhow, the results of this study were pretty good. So this is a case that I want to show you. This is just an ostial circumflex with this disease. And it's not a very appealing place where to put a stent unless you want to go with a dual complex stenting with DK crush or culotte or whatever. So here we prepare the lesion, and then at this point, we use a scoring balloon in this case, we decided that we wanted to go with DCB. So going with DCB in this case is only a matter of drug delivery, because what is very important is to what you do earlier before lesion preparation, and then this is the final result. Of course, if you use only DCB without implanting stents, like in this case, you may expect some carina shift, which there was, but it was very limited in the ostium of the LAD. And this is the 6 months angiographic follow-up, still showing a pretty good result in the circumflex with the patient, which is asymptomatic. So this is a quite simple, straightforward case, which is showing how simple can be to manage bifurcation lesions, in this case, a Medina 001 with drug-coated balloons. So one of my goals today is to underline how we should perform a DCB PCI for bifurcation lesions, and I cannot skip underlining how important this year was for the publication of few papers. The first one is the DCB ARC, published in the European Heart Journal and Eurointervention. Here, a group of experts from all over the world is showing and is underlining how clinical trials with drug-coated balloons should be performed for the future in order to gather and to obtain a sufficient level of evidence-based medicine. And then there is another paper which was published like 2 weeks ago in JACC, and this is a more detailed and technical paper on how are the indications for usage of DCB, and a specific chapter of this paper is underlining how we should perform a DCB angioplasty with for bifurcation lesions. Either we want to use a stent in the main vessel and use the DCB just for the side branch, or if we want to go for a full DCB revascularization, which is something that is not suggested as a routine, but only in selected cases so far, due to the lack of evidence-based medicine. And then there is also a nice paper written by Simone Fezzi. It's a review published 1 or 2 weeks ago, same on Eurointervention. And this is a very technical review paper and also a literature review on how we should perform a DCB angioplasty for the side branch in bifurcations, either simple or complex bifurcation lesions. And so from this arises my second case with this diffuse disease. This patient had a stable angina, was a male with stable angina, diffuse disease in the LAD with this sequential bifurcation, proximal LAD disease, first diagonal, second diagonal, and mid-LAD disease. So again, here you cannot commit in using 1 DCB, 2 DCBs, or how many DCBs you want unless you prepare the lesion. So this is what we did. This was not a calcific lesion, so we just used semi-compliant balloons and non-compliant balloons just for the proximal LAD. And then at this point here, after you assess your lesion preparation, you decide if you want to go with DCB. And we thought that we had obtained a good, an adequate lesion preparation here for going with a drug delivery, which is what we did. We use a DCB for the ostium of the LAD in the diagonal branch 1, a DCB in the diagonal branch 2, and a DCB in the mid-LAD as well. And this is the final result. You always have to wait a few minutes. You always have to take an orthogonal view to see that you don't have recoil, to see that you don't have a flow limit in dissection. And here the flow was pretty good with this type B dissection, and the result was considered decent. And we also have an angiographic follow-up here at 3 months with still not a complete healing of the dissection, but with a very good flow. So we consider it a successful PCI of solo DCB. But as I said, solo DCB PCI for bifurcation lesion does not have today a sufficient level of evidence for suggesting it. So this is why we are running. There are two, to my knowledge, two trials running, one in Europe and one is Picolet of 5 from our foundation. This is a non-sponsorized, investigator-driven randomized clinical trial. We prepare the lesion correctly following the DCB ARC suggestion. And then if we have a good lesion preparation, we randomize patients to stent EBC-like, which means provisional stenting, to full paclitaxel DCB with sequential DCB inflation versus full sirolimus-coated balloon with sequential sirolimus-coated balloon inflation. And then we will assess the patients during a 9-month CT scan functional assessment assessed by a core lab. This trial started enrolling patients 3 months ago, and it's still a long way to go, but we will see. And importantly, from the technical standpoint here, we don't use kissing balloon. We don't use kissing balloon. We prepare the lesion. We just dilate the side branch. We dilate the main vessel. We deliver the drug in the side branch. We deliver the drug in the main vessel. And importantly, we don't accept kissing balloon in this trial, as I already suggested, and we may also accept, and this is something that is deviating from the DCB ARC recommendation, up to maximum 70% stenosis in the side branch, because we have seen from other studies earlier that also if you leave that kind of stenosis after delivering the drug is still working well, specifically paclitaxel has shown to work well. And this is my last slide. I'm happy to respond to any question. And if you want to go a little bit deeper into that, sorry if I do that, but I'm doing some advertising for our DEVS meeting in Europe, in Rome, for the next February. Thank you for your attention.
Thanks, Bernardo. That's great. Are you doing physiologic assessment routinely when you do standalone balloon angioplasty on these vessels? And if so, are you using it before or just one?
No, we use it only in selected cases. We have a few cases, but we don't have enough experience to suggest it on a routine base. I think it's appealing. The idea is appealing, but there is paucity of data for the bifurcation setting so far.
Bernardo, great presentation. And I think there are lots of really key points you highlighted there. But there's one that you kept saying, and I completely agree, but I want you maybe to give some context. You keep talking about not doing kissing inflation with drug-coated balloons. Maybe let's share with everybody why you think that's a bad idea.
Yeah, so I think that we shouldn't use, but I think that all of the guys here do agree with me, and I want to know also their opinion, kissing balloon also for lesion preparation. So first of all, we don't want to use a stent. So if we use kissing balloon, you can imagine the proximal vessel with these two balloons which are inflated. So this is increasing, theoretically, the risk of dissection in the main vessel. This is the first point. The second point is that we may, with a normal routine 6 French guided catheter, we may lose drug. We may lose drug if we advance. Also, if we advance the first balloon and then the second one, we may lose drug. So probably you want to comment, Azim, on the study that you did. I don't know if it's a bench test or an animal study on how easy it is to lose drug after DCB if you use any probe or if you use any device after delivering the drug. So it's the same concept. If you use 2 drug-coated balloons and advance together, you may lose a lot of drug.
Yeah, absolutely. You know, we actually tested this in the visible heart, and we're preparing some images to show everybody in the future. But when you put 2 drug-coated balloons together and inflate them together in the proximal main vessel, you get very non-homogeneous distribution of drug. You lose a lot of drug, but you don't actually cover the entire vessel wall. So it's why I wanted to highlight what you were saying. I think in the past, people thought it was okay to use kissing DCBs, but I think, all of us with experience think it's a bad idea because you lose drug. But now there's also some, preclinical data that shows that very, very clearly you don't get homogeneous apposition of drug. Bill, should we move on to the next talk?
Yeah, I think one good question came through that maybe we can answer quickly, but the question was about using semi-compliant, non-compliant versus scoring balloons for the side branch, and I'm curious what your preferences are and what % you think you use scoring balloons.
So we are using scoring balloons more and more. To be honest, this case was done in Europe, the second case a few years ago. Now, in our casuistry for de novo, we use scoring balloons in like 60% of the cases. So with mild calcification, with osteal lesions, osteal side branch, with moderate calcifications, that's our first choice.
That's
Right.
great. So I think Dr. Alfonso is next, I think, to
Yeah,
present.
go to Fernando. And then we'll answer some of these other questions. Maybe Fernando, I'm sure this will come up in your presentation too.
Okay, can you see my slides?
Yes, we can.
Yeah.
Okay, so thank you very much. Pleasure to be here with friends. Thank you to SCAI, to the host and to the moderators. It's a pleasure for me being here. And my role today will be just to share with you this, I would say, simple case. So this is a patient we treat a couple of weeks ago in our hospital, Hospital Universitario de la Princesa. So this is a 93-year-old man, smoker, hyperlipidemia, chronic pulmonary artery disease. He had this problem, a colostomy after ischemic colitis with ureterostomy, but no bleeding episodes from that. And the patient appeared to be frail, 93 years, but was rather autonomous and was able, to go out a bit every day. So the whole thing started a week before a presentation 3 days later with some episodes of effort angina, and eventually he suffered from a prolonged, quite clear angina-like chest pain at rest. So arriving to the hospital, we noticed a quite clear peak of biomarkers, as you can see here. The echocardiogram show a preserved left ventricular ejection fraction with just mild anterior hypokinesia. The patient was only on aspirin at the time. This is the ECG on admission. So you can see these quite clear negativity waves from V1 to V3. And obviously we underwent coronary angiography. So as you may see here in this RAO caudal, there is a rather severe lesion at the distal part of the left main involving the circumflex coronary artery, which is a large vessel. The circumflex itself was with disease in the mid part, and there was also a very minor final branch of the circ with severe disease. There is this intermediate ramus with disease, and the proximal part of the LED was also diffusely diseased, and this is better depicted in this cranial projection. So it's quite clear that the left main is tight, and there is this diffuse disease in the LED. And here you can see the caudal, the spider view, which is very good to delineate that this is in fact Medina 111 bifurcation. So the right coronary artery was dominant, beautiful posterior descending artery, but in the cranial view, we were able to notice again another borderline lesion in the mid part of the PDA. So this is it. I mean, 93 years old. There was some compromised anterodiaconate flow in the left anterior descending coronary artery. And we decided to proceed during the same procedure. The idea was to treat the left main, LED, and left circumflex coronary artery. So we first predilate to get a good flow. So this is a dual balloon dilation, semi-compliant, just low pressure of 14 atmospheres to the LED. And immediately we perform another predilation of the ostium of the circumflex coronary artery, again with this small balloon at 14 atmosphere. So then we decided that we needed crossover stenting from the left main to the LED. So the best approach to the circumflex coronary artery would be DCB. So for that, lesion preparation is crucial, and this is the result of the initial preparation, but then there was a preparation with very high pressure semi-compliant balloon, and after that, 20 atmospheres with a non-compliant balloon. In most cases, when we try to do this strategy, we use a scoring balloon, but the result of the non-compliant balloon was very good. The balloon had no wasting to projections, so we decided that this was good enough. And finally, Plaquetaxel balloon was inflated 3.0, 15 millimeters in length, 2 times because the balloon was obstructed the left main, 2 times without moving the balloon, 30 seconds each. Then we perform an OCT run, not in the circ, but from the LED. And as you may see here, we wanted to make sure that the ostium of the circumflex coronary artery was nicely open. There was no carina shift or plaque shift. And you can see this is steel frame, which is quite clear in this regard. So this is the OCT pullback from the LED. And this is the OCT pullback. This is proximal, left main, going to the distal, and this is the proximal left anterior descending coronary artery. Let me try to play that slowly for you. So this is left main. You may see the 2 wires. So this is the disease at the end. You may see here the entrance of the circumflex coronary artery with the wire getting in. Nice opening of the circ. This is the proximal ostium of the LED, and this is the proximal left anterior descending coronary artery segment. Okay. So after that, we implanted a drug-eluting stent. Accurate ostial stenting was impossible here, so we decided crossover, and we used this sirolimus eluting stent. We choose a rather small stent, 3.0, but then we upgraded that using POT 4.0 millimeters with a nice angiographic result, as you can see here, and a nice result of the ostium of the circumflex coronary artery. Here's the cranial view. And we perform OCT again from the LED to the left main. Now it's going in the opposite direction. Remember, this is proximal, and it's very clear that there was significant malapposition of the proximal part of the stent despite the POT that we performed. So an additional POT was performed quite gently because it was rather overexpanding, 2.25 millimeters, trying to address this problem in the proximal part of the stent. Let me try if I can show this. So this is the proximal left main, beautiful angiographic result, but obviously you don't see that on angio. And after that, we perform a 4.25 post dilation with a semi-compliant balloon, but we didn't perform another pullback. But let me show you also the final part of the stent in the LED. Some blood there, so it's not beautiful, but it's quite clear that there is a nice transition from the stent to the distal vessel. There you are. So we were satisfied with this result. So the patient had an excellent clinical course, was discharged 3 days later, and we saw him a couple of days ago, and he's back to normal life and happy. So this is my case, and happy to address any question.
It's beautiful. One of the questions that came up was why not stent the LAD first and then open the struts and DCB the circumflex second?
This is also a very nice strategy, but once we got a nice flow in the 2 vessels with the predilation, we had time to think, and we decided in this case that, trying to optimize carefully the ostium of the circumflex coronary artery that we did allow us plenty of opportunities rather than stenting the LED and the left main. But again, this also another strategy. I don't think there are studies suggesting one is better than the other.
So Fernando, Bruno and I tested this in the Visible Heart Lab. So in the Visible Heart Lab, you can actually see the drug being deposited on the vessel wall when you inflate a balloon. And so we tested both strategies, which is when you're doing provisional, do you do DCB in the side branch first, then stent the main branch? Versus we stent the main branch, open with a normal balloon, the struts, and then DCB the side branch, right? And I can tell you that the approach you just showed the best drug delivery to the side branch, because you didn't lose any drug when you were trying to pass the struts of the main branch stent. So I really like it. I think it gives you the best apposition of drug. The only question that people ask on the chat and physicians when we show them your approach is, what happens if after you stent the main branch, the side branch looks worse? And now you have to open the struts or do kissing balloon, you're going to lose the effect, or maybe you're going to lose the drug in the side branch. Any comments?
Well, the comments is that until now, all the experts in DCB were emphasizing that this was not a problem. I mean, until 2 years ago, everybody was quite satisfied with that, even though we have no data. And, from a practical point of view, you always are concerned. Now, more and more people are warning and asking to be cautious regarding this strategy. But at the end of the day, if you follow this strategy and there is a poor result in the circumflex coronary artery, which is quite typical of crossover stenting, either plaque shift or carina shift or whatever, then you need to come back. And well, I don't know, but I think you should try to fix that with high pressure balloon going 1-to-1.
Right.
Bernardo, you were saying something.
Yeah, no, I agree with this strategy. This is the strategy that we try to apply. And there is also another reason, because if you can avoid distorting the stent struts, by predilating and then going with the DCB, it's probably better. So the less we distort, our stent struts, the better it is. So there is also this reason, because this may lead to some distortion and some change in the flow into the main vessel as well.
I think, Bill, that answers a lot of the questions. There's been a lot of questions from the audience about the approach to, the side branch. Bruno, before we go to your case, any thoughts on what's your practice with provisional? Do you go with the DCB after the main branch stent or before the main branch stent?
Typically, we go first with the DCB to the side branch and then try to forget the side branch if possible for the rest of the procedure, and then do the job in the main branch. So I think if this works, this is the easiest and best strategy. However, as you said, in some cases you have to recross because the side branch is severely hampered, and then it's a different scenario, of course.
Yeah, absolutely. And I think also, I love this case, Fernando, because, when we do left main, the circumflex ostium has really been the biggest challenge for me. And I think trying to avoid stenting and doing a double stent approach using DCBs to prevent a second stent is a great approach. So maybe we'll move on to the next presentation. That will give us more time for discussion. So Bruno, you're up talking about a calcified bifurcation.
Yes, I did it in brackets because I think it's a general discussion we can do on the treatment. Can you see the slides?
We can, yes.
Oh, great. So something I think is impressive is this picture from a publication from the European Bifurcation Club, which shows you that if we treat a bifurcation, we have to deal with different vessel areas and vessel diameters. We have to deal with different angles, and all of these things are not optimal for a constant tube like a stent, which is the same diameter in the proximal and the distal part, and does not include such angles which are not 90 degrees. And we also know from the trials, I mean, the data are mixed, but at the end of the day, I think a two-stent strategy may lead to inferior long-term outcomes compared to provisional one-stent strategy. This picture has been shown, this paper by Bernardo in his talk. This is a more technical paper which has been written by Simone Fezzi. And this illustrates you the different strategies, how we can use DCB and bifurcations. And we have talked a lot in this session about the strategy using a drug-eluting stent in the main branch and using a DCB in the side branch. And one of the key questions is what is the right sequence in this concept. The other more puristic approach is the leaving nothing behind approach, where we try to treat both branches with DCB only and avoiding completely a permanent stent implantation. And for this scenario, as Bernardo already showed, in my opinion, the best way to do it is a sequential way. Start lesion preparation, for example, in the main branch, then do lesion preparation in the side branch. If it's fine, deliver the drug in the side branch, forget the side branch, and then, if possible, deliver the drug in the main branch with the option, if the result is not satisfactory, to cross over to stenting. So I think that's a reasonable strategy. My patient is a 69-year-old male, multi-morbid patient. We did several weeks ago a TEER of his mitral valve. He has a reduced left ventricular function, 38%. Is on atrial fibrillation with the need for anticoagulation, so in HBR patients. He has a pulmonary disease which limits also his life, and he has a two-vessel disease with in the past drug-eluting stent in the mid-diagonal branch, and on the 2nd July of this year, he was referred to us to the planned treatment of a calcified LED D1 bifurcation. This is the right coronary arteries of this patient, lots of disease, but no high-grade stenosis. And here you can see the calcification of the LAD already without any contrast. And this is this bifurcation we are talking about. It's if you look carefully, it's a Medina 111 with a severe disease here, also in the proximal diagonal. The more distal part here, where the drug-eluting stent, it looks fine in this patient. So the question is how to start lesion preparation in this scenario. I think if you see this amount of calcification, it makes no sense to start with semi-compliant balloons, but because this will result in dissections, but not really create sufficient lumen. So the decision was to start with non-compliant balloons. In this situation, we typically start with smaller balloon sizes than we intend to use at the end of the procedure. This were 2.5 balloons, in both directions. And what you can see here is some improvement in the lumen, especially in the main branch. However, if you look at the side branch, this is still not satisfying lesion preparation. And the next escalation step for me is then to use specialty balloons, cutting or scoring balloons. In this case, we used 2 scoring balloons in the main and the side branch. It was a 3.0 with close to rated burst pressure in the LAD and at nominal pressure in the origin of the diagonal branch. So this is then the result. You can see that we have improved our lumen, and this fulfills the criteria of a successful lesion preparation. We have no flow-limiting dissections. We have reasonable lumen gain. Diameter stenosis is less than 30% by eyeballing, and we have an excellent flow. So this is a really good lesion preparation. If you do not reach such a result in severely calcified lesions, then the next escalation step would be to use IVL, or at an earlier stage, rotational atherectomy, which could be the option. But in this case, I think we are fine, and we decided that we are done with lesion preparation. And then there was a sequential use of 2 paclitaxel-coated balloons. This was Prevail, 3.0 by 20 in the side branch, and 3.5 by 25 in the LAD. We do never do kissing DCB. As discussed before, this makes no sense. And here you can see the OCT in the LAD. We are here in the distal part of the bifurcation. Here is the treated area. You can see that we have created dissections, multiple dissections, but in all cases we have the true lumen is much bigger than the dissected lumen. And you can also see that the origin of the diagonal branch also looks very nice here. And here we have also, again, the OCT from the diagonal. You can see here the tracheotomic stent, which looks fine. Then we go back to the LAD, and here once again, we can see dissections, but we always see that the true lumen is bigger than the false lumen. And this is the angio. You have always to look in at least 2 projections to verify your result. And here again, we see a good flow after DCB treatment. We have no flow limiting dissections, and we have a good initial lumen gain. So that's the approach, I think, which makes sense to apply for bifurcations. Bernardo already showed the design of one of the trials now investigating this puristic approach of DCB in bifurcation lesions. The other trial is the European Bifurcation Club DCB study. Here, 750 patients from 8 countries will be randomized in a one-to-one fashion to this puristic DCB approach I showed you versus a provisional stent implantation according to the EBC criteria. And here already the first patients have been included. We did our first case last week. So my summary is that bifurcations are frequent in our daily practice. Provisional T is still the most frequent used treatment strategy, which makes a lot of sense still. We know that DCB reduce lateral loss and possibly TLA in the side branch, but it is, at the end of the day, it's unclear if this reduction of restenosis in the side branch really will improve the clinical outcomes of the patients. The use of DCB in bifurcations make the procedure much easier, much simpler, in most cases faster. Lesion preparation is key, and if we are talking about calcified lesions, I think there is an escalation strategy in lesion preparation. Don't use semi-compliant balloons, start with non-compliance, then use specialty balloons, and if necessary, rotablation or IVL before DCB treatment. And there is upcoming clinical evidence to give us more data and support this approach. Thank you.
Thanks, Bruno. That was great. Bruno, there are a couple of questions that are coming up that I think are important from the audience. The one is, as relates to utilizing intracoronary imaging after you've delivered your DCB. I know what your approach is, but if you could share with the audience, please.
Yeah, so what I showed you is not the best approach. It makes much more sense to use intravascular imaging for planning of your lesion preparation and guide your lesion preparation. But you should not decide on the result of the intravascular imaging if you end up with a stent strategy or with a DCB strategy. That's very important. Therefore, the use in the beginning of the procedure makes a lot of sense. Before DCB, I would not really do this for this decision making.
Let me ask you a question, and I think I can almost sense Dr. King sensing this too. I mean, early on, you know, Dr. Grunzig, when he did angioplasty in an early left main, that had a great result and then had sudden death several days later. How are, like, we're taught, and this is, I think, going to be a little bit of a resistance in the U.S. for some of the strategies, is the concern about leaving dissections behind because of the fear of acute closure. And we always see these, like your case is absolutely beautiful, but we never hear about the cases that closed that night or had a sudden acute closure early on. And I'm wondering, why aren't they closing when they used to close? When you hear the horror stories of the early days of angioplasty, so if they're not closing, why aren't they? Or why? What are we doing differently? And what's been your experience with leaving some of these things that we're super paranoid in the United States about leaving any dissections behind?
Yeah, very, very important point. There are several reasons why it's a different thing we are talking today compared to the earlier times. In the earlier times, there was one balloon type available, which were semi-compliant to my best knowledge, and that's it. Nowadays, we have non-compliant balloons, we have specialty balloons, and specialty balloons are an extremely good tool to modify dissections. If you have a huge, large dissection in your artery, you can cut it in smaller parts. And this modifies potentially flow-limiting dissection in most cases to benign non-flow limiting dissection. That's number one. Number two, we have dual antiplatelet therapy. You have always microthrombus formation after angioplasty, but you can control it at a certain amount when using dual antiplatelet therapy. This is also different to the earlier days. Today, in addition, we have the possibility of measuring physiology or doing intravascular imaging further to differentiate between benign situations and less benign situations. And what's also different from earlier days is we have always the option to cross over to stenting if we are not satisfied. I think that makes the big difference to the earlier times.
Yeah, I think, that's the biggest challenge for all of us out there. And I know me and Bill and a lot of us feel strongly that we need to together as a community come up with objective criteria to help our colleagues about which dissection we can leave, which dissection we can't, because a little bit now, we talk about type C, type D, but I think we can come up with better criteria. The one thing that also comes up from the audience, and maybe Bernardo, you mentioned, and I don't know if Fernando or Bruno do this, you mentioned you wait a few minutes when you finish the end of the procedure to make sure that, and you do two orthogonal views, which I like, but you wait a few minutes before you do those two orthogonal views, just to make sure that any dissection is not getting worse or is not about to close. When you do that, do you pull the wires back too? I mean, we always taught that the wire may be keeping a flap up, and that when you pull the wire back and then suddenly the vessel is going to occlude. Maybe just if you can quickly share your approach.
Yeah, usually, I'm sorry, Bruno. Please go ahead.
No, please.
Well, let's hear both of you. Anything different?
Yeah. So usually we keep the wire for a few minutes, but after really thousands of cases, we can anticipate if that vessel is going to recoil or not, to be honest. So you are completely right. We need to have more standardized and shareable criteria. But so far, I think that the only criterion that we have is deriving from the experience and from angiography. Lacking still with, as Bruno said, important data coming from imaging or physiology. So they are still lacking. Okay, it's a work in progress. We are working, several groups are working on that, but still we are relying on angiography. So I have to be honest, I leave if I don't expect to have recoil, I remove the wire. If I have some dabs, I keep it. So there is no, not just a general rule.
Bruno?
Yeah. So what you mentioned, it is important to see the time course of the dissection you create. If they are stable during the procedure and they are not progressing, and you have to wait sometimes, and you have to look in two projections and have to look, are they stable? Is there no progress? Then you can be very sure that it's okay if you take the wire out. But if you see that there is some progression of the dissection over time and you cannot modify, for example, with specialty balloons, then this is a high alert for me, and then I tend really to stand it to be on the safe side.
Another question that just keeps coming up, sorry, Bill, is DAPT. And maybe, do you treat bifurcations differently? What is your approach to DAPT after a DCB only strategy?
Let me just
So-
tail on to that too. Are you pre-treating everybody, for days on end when you come to the lab, so you know that they're inhibited?
I would also add one more to that, just to make it complete. Do you use rather ticagrelor versus Plavix when you're doing DCB only, or do you just use standard? So maybe a few questions around DAPT and sharing your experience, please.
So we have no randomized controlled trials so far really answering this question. But what most groups did in the trials is that if you do not implant a new stent, we are fine with 4 weeks of dual antiplatelet therapy. And we are doing this according to the usual guidelines. This means if the patient is in a stable situation, we use clopidogrel. If the patient has an ACS, of course, then we use ticagrelor or prasugrel, and for 12 months, of course, because this is according to the guidelines. So that's the situation. But if we are in a stable situation, we have no new metal which we implant, then our standard is 4 weeks, and this is also done in most of the ongoing trials.
And do you pre-treat? I mean, you want everybody preloaded on the day, or do you pre-treat a few days before, or it doesn't matter?
We do it on the table if the patient is treated.
Okay.
Just great discussion. So I think appreciate all the insight. I think we need to, just in paying attention to time, Dr. King has a talk that we'd like to get to too. Spencer, are you there?
Yeah, so do I share my slides? Is that the way I do?
Yeah.
Okay, see what happens here. That was the share, and that didn't come up with my slides. There we go. So, yeah, I appreciate what all you experts in drug-coated balloons are learning. It's a fascinating time, and what you've asked me to do is reflect back a little bit to balloon angioplasty without stents and what it was like. And before I tell you some of those observations, I would say that trying to advance my slides, which are not advancing.
Dr. King, you can press
Maybe
one of the arrow buttons on your keypad.
Yeah, I am pressing, but it's not advancing. I don't know what's.
Yeah, let me see if we can do it from here. Can you try a space bar? See if that works.
That doesn't work either. It must be.
Alrighty. Well, how about we on staff go ahead and share your slides? One moment, please.
Yeah. Okay.
Just getting that set up.
Well, that's happening. Let me ask the experts. When you do sequential DCBs, obviously you're going to have some of the main branch that's going to get double coated with your medication. Have you had problems or concerns about that? Are you worried about aneurysmal formation, or has there been any issues with that?
I think it's a matter of sizing. So, for example, if you have a diagonal branch 2.5, and you have then a 2.5 balloon in a 3.0 or 3.5 LED, there's almost no contact with the vessel wall in this part. So the drug goes down, then that's the disadvantage. But it not really creates some kind of double dose in this situation.
I mean, I think where people are very concerned, Bill, is what happens when you have to bail out stent, right? And now you're already treated with paclitaxel, and now you're putting a Lima stent in the same area, and there's 2 drugs and a double dose. I have to say, there's a lot of data, and we actually have a large registry coming out now with like almost 600-700 lesions where this was done. And we've not seen any negative consequences of the double dose, and with 2 different drugs. We've not seen any aneurysms or an increase of late stent thrombosis. Sorry, Bernardo, I didn't mean to interrupt.
No, this is very interesting what you said. And just to point out, there is only one case where I would like to avoid double dosage of drug, which is if you create a big dissection, which is, you create a big dissection, the flow is good, the lumen is large. So you would say, okay, let's finish with the DCB. In this case, I would like to avoid using double dosage of drug.
Go ahead, Laura. Yeah. So going back to balloon angioplasty, you've got to reflect back. And this of course, was the first NIH trial, sponsored trial, and that was the East trial we did here at Emory. And so angioplasty, the old-fashioned angioplasty worked compared to surgery in multivessel patients for 3 years, according to this. And however, we had a core lab for the efficacy of whether it actually treated the lesion. Next slide. I guess I have to say next slide every time. This was our core lab at the University of Washington, and we looked at the effectiveness. Next slide. And what we saw was that if you just looked at successful revascularization of the segment treated, at 3 years, you see up there the surgery obviously had better success than PTCA. High priority segments, the difference was a little less. And then if you looked at severe segments, it was quite comparable. So this is all, yes, the patients live the same with surgery or PCI, but this required an enormous number of repeat PCIs and surgery in a lot of these patients to get these kind of results long term. So we don't definitely want to go back to PTCA the way we had it. Next slide. So here's some of the lessons I think we could learn. The balloon size, you've talked a little bit about the dilatation pressure, the pressure gradient and how it's maintained after you pre-treat, the influence of tear dissection, and the influence of balloon occlusion time and inflation time. Next slide. So some of these studies we did, we learned a few things, and I'm not going to show you the studies, but just kind of what we learned from some of them. The balloon pressure, we found that, these were very low burst balloons, as you pointed out. These were compliant, semi-compliant balloons. And the first ones they had a rated burst of 7. We went usually higher than that, but then finally we got better ones. And then we learned that, okay, higher pressure works better, and really you can't get the lesions open with those low pressure. So this, I think, carries over till now. High pressure is usually a good thing. Next slide. Balloon size, maybe a little different. We did a randomized study comparing larger balloons to smaller balloons, and sort of oversized balloons, thinking that might be good. What we learned from that was that larger balloons did indeed cause dissections, and in this case, a lot of these dissections were bad dissections. And you see, we did emergency surgery almost twice as often in the ones we randomized to the large balloon, oversized balloon. So that is not probably a good idea. Next slide. Here's the influence of the balloon size on bypass surgery. You see on the left, and then on the right, you see it didn't affect restenosis, but it did affect those acute complications. Next slide. And then we learned that dissection by itself was, in fact, not a bad thing in terms of restenosis. Here was a large number of patients who had visible dissection, but 9% of those had complications, and you see the complications listed. bypass surgery, of course, was the one you were most concerned with, and it was 3.6% of the total group of people who had dissections back in those days. Next slide. The things that related to acute closure, pretty obvious. The percent stenosis you're left with, dissection was a predictor of acute complications. Prolonged use of heparin, of course, that was predicted because we thought something was wrong and we continued heparin. The branch point location, other things and lesion length predicted acute closures. Next slide. Next slide, please. And here's another study on the morphologic predictors. Again, tear dissection comes up as a predictor of the acute complications. Next slide. Now, in terms of restenosis, the real thing that we were most fascinated with was that dissection was not a predictor of restenosis. In fact, the absence of dissection was a predictor of patency. And also the final gradient was important. We've talked here a little bit about recoil. We saw a lot of recoil in these patients. And so the gradients were measured with fluid-filled balloons. So a 15 millimeter gradient was quite a low gradient. Now, of course, that would be totally not correct with a pressure wire, but with a fluid-filled balloon, that was good. And then an observation over time, if that gradient began to increase, that was a high predictor of complications of acute closure. But the dissection itself was not a predictor of restenosis at all. Next slide. So that was what we concluded, that uncomplicated dissections after successful angioplasty had no adverse influence on angiographic restenosis. Next slide. And here's the actual numbers. You see that there was a trend toward a better outcome when you had intimal dissection visible versus not having it. Of course, what that meant in those days was probably that the ones who had no dissection maybe had inadequate dilatation. And translating that to now, that means they probably had inadequate lesion preparation. Next slide. Now, the length of inflation, that's something also I think we learned a lot about. And we tried to get around that in the early days with perfusion. We would perfuse oxygenated fluorocarbons and Ringer's lactate through the balloon, a lumen. And later we did that with, of course, perfusion balloons. And we found that longer inflations were better. You get a better angiographic outcome, less final stenosis and less gradients with a prolonged inflation. So I've always been frustrated with the very short inflations done during the stent era. And you can get by with it with stents because you can just give a little, okay, let's go up 10, 12, 14, 18 atmosphere. Okay, down. And that's what I hear in the labs all the time. Blow it up and immediately down. I don't even know if the balloon achieves the pressures. But with stents, you get by with that usually because the stent holds the artery open against the recoil. But I think you don't achieve adequate effect of the balloon unless it's up for a period of time. Next slide. We know later this top reference has actually got to do with stents. Stents do better if you leave the balloon up longer. And the one below is with perfusion balloons where very long inflations did also were effective in overcoming the recoil, making sure that the artery, the resistance has been overcome. Next slide. So finally, how do arteries heal with you stent them or you don't stent them? They're very different. So our experimental work showed us that in the porcine model, if you balloon the vessel, the proliferation is over in a couple of weeks. Obviously, in people, it's longer than that. But if you stent the artery, this may be the reason that we see 2% attrition in stented patients over the years. And I guess it's the main reason that you're all going back somewhat to trying to avoid the stent. Next slide. So why do stented arteries have more intimal proliferation? I think the chronic stretch of the media and external elastic lamina and inflammatory reaction of the foreign body all have a role to play, and we thought that back then. The next slide will show you some of the reasons that we thought that. You see, here's a porcine artery dilated, and the healing occurs in the area where the media is split. The next slide shows another example. Here's one of your dissections that you worry about, but the healing occurs and the proliferation occurs in the area split, not in the whole artery, not because here there's no chronic stretch, there's no tension, there's no smooth muscle cell elongation and stretch. It's this powerful stimulus of proliferation and migration. Next slide. However, with stents, what you see, of course, is you do have a chronic injury and stretch, and the proliferation is usually all the way around the vessel. Next slide. So delivering the drug, of course, is what you're after to try to reduce even the proliferation that you have after balloon angioplasty. And we saw this when we got involved to develop the brachytherapy work in the early 90s. And so you're doing the same thing with paclitaxel or sirolimus these days. Next slide. So what are my conclusions? Coronary angioplasty results before stents did reduce angina and were had an acceptable complication rate for that time, not for this time. For this time, we don't want to go back to just what we were doing 40 years ago or more. Some lessons maybe can be learned from that experience. I've shown you a few. Coronary angioplasty now, however, is very different, and new lessons need to be learned. And I'm impressed with what I'm hearing from the experts who've done thousands of these and the lessons you're learning. Back then, when it didn't work, bypass surgery was the bailout. Today, the bailout seems to be stents. So I've enjoyed listening to you all. I appreciate it. Bernardo, I've read with great interest the paper on future trials and you and your colleagues put together. And it's an exciting time. I'm a bit jealous whether you guys are getting to get into a new area of interventional cardiology that maybe will give us new insights in the future. Thanks a lot.
Thanks, Dr. King. That's just wonderful discussion. So I don't know whether you want to have a little more, we're a little bit over the time, Azim. Do you want to have any other?
No, I'm so glad you made Spencer do that. Dr. King, thank you, because I think there's so many great lessons from the past that we need to not have forgotten, because I don't think we're completely reinventing the wheel. When I see those papers, I'm a little embarrassed that I didn't know some of them myself, but I'm going to be going to read them up and using them in my future presentations, because I think we really have come full circle, and the lessons that you guys figured out in those days, are still very relevant today. So thank you so much for that.
May I have a word? So I do remember, I was very interested in the talk. I do remember when I was in training, reading those papers with enthusiasm. So all the basis of balloon PCI that may be a little bit different from DCB now, but all these little details that are important were already settled. Now, the issue is that young guys learn to put stents, then are learning that perhaps, having a dissection is not so bad, but have no idea of these key and basic questions. So Spencer, I think you need to summarize that in a paper because most young
Yes.
people have no idea of all these, let's say, basic and classical things from balloon PCI and are equally needed.
Fully agree.
It's great.
We're coming to the end, but I want to share a screen for just a minute, okay? So let me just put this up here. So I want to talk to you about, we've been doing angioplasty courses at Emory since 1981 with Drs. King, Grunzig, and Douglas, and now we would have a course next year which Bill will talk about. It will be Return of Balloon Angioplasty in the Modern Drug-Coated Balloon Era. We have a fantastic faculty, and many of you are going to be participating in that. And I'll let Bill discuss this.
Andrew, thanks so much. I don't think your slide's showing, but if you want to.
Really? Does not?
And showing.
Don't show?
Yeah.
Sorry, let me see this. I just shared.
But I think what Dr. King
Can you
just
see it
spoke
now?
about. Yeah, we
Can you
can.
Okay.
So, I mean, we're really excited about this. We're going to do this April 16th and 17th in person on Emory's campus back in the original auditorium where Dr. Grunzig did the original courses with Dr. King and Dr. Douglas. The faculty is just really like who's who of the history of interventional cardiology and the modern pioneers and experts in the field of angioplasty and DCB. And really, like, you know, for if you're under 60, you never really learned how to do angioplasty. And so, you know, the whole goal of this is to sort of have a couple different points, but bring back the pioneer legends and combine that with the world experts with an absolutely fantastic faculty. With the goal to develop what is alluded to before was sort of a consensus on what's an optimal or acceptable result, you know, based on different criteria that we kind of have a consensus agreement with that with some live case and discussions. Goal would be to come out of that with a consensus paper, and then we've already got a REDCAPS registry put together that we'd have a multi-center participation in a database from that, and then obviously recreate this iconic photo that you've seen plenty of times in the past that have all the legends of early angioplasty days done in the same auditorium. So we invite you to come. We're not charging any registration fees. It's going to be on site. It's not going to be webcasted, but it's not a huge auditorium, but it'd be 250 people or so. Obviously, people that come can contribute to the consensus paper as well. But I think when you look at the faculty that's there, it's like for me or anybody that's really into interventional cardiology, the opportunity to get this group together is a rare thing, and I think a historic opportunity. So you're
Bill, we're collecting the historic picture here. We may have to update that to the Emory.
Yeah, it is.
Well, thank you, everybody, and particularly to our participants. It's a great meeting, and thank you for our European colleagues to come on over. I know this is a later in the day for you, and thank you to my mentor, Dr. King, for taking the time to lead us again, and thank you to Bill and Azim for this fantastic course. And so we end this second series of webinars for the SCAI Bifurcation Club. It's been a privilege for me to host this and plan for the past 2 years, and I'm going to pass it on to the next group of leaders who might be interested in doing that. And thank you to SCAI for allowing me to do this. Appreciate everybody on board.
I think it shouldn't go without saying congratulations to Tanvir for what he's put together. It's a ton of work, and it's been an extremely successful series.
Yeah. Agree. Thanks, everyone, and thanks to the speakers, and thank you for joining and all the great questions.
Did Dr. King have to say something? I think he just did.
No, Tanvir, just thanking you.
Well, thank you. Thank you very much. Thank you, Laura.
Thank you, everybody.
And Amanda, and for SCAI as well. And thank you for coming on this Saturday. Bye now. Thank you.
Bye-bye.
Bye-bye.
Bye-bye.